Hi there. Welcome to the webinar Going Digital in Pathology. My name is Juan de Romero. I'm an anatomical pathologist and I'll be hosting the webinar today. Thanks very much in advance for your attention. A couple of words about myself before we delve in. As I mentioned earlier, I'm an anatomical pathologist and my area of expertise is digital transformation of pathology. I was very fortunate to be an early adopter, a pioneer in digital transformation for routine clinical diagnosis back in 2016. From that point onwards, my role as a pathologist evolved into that of a consultant in digital transformation, which is what I've been doing essentially with my professional career ever since. I was fortunate enough to join Paige back in March 2021. So a couple of words about the agenda that I'd like to discuss with you today. First of all, I'd like to share my experiences with digital pathology for routine clinical use from the point of view of an early adopter. The highlights, the shadows, and also the lights. We'll also discuss why pathology needs to be modernized. Next, we will go on to what pathologists like about digital pathology, and more importantly, what pathologists do not like about digital pathology. Then we'll discuss the journey towards going digital and implementing artificial intelligence in routine clinical use. How do we get started and where do we begin? We'll also discuss the challenges, most importantly, how to tackle them, the solutions that, in my experience, we can find for these challenges. We'll then wrap up the session and we'd like to then open the floor for questions and answers. So this is where I cut my teeth in the world of digital pathology. So I was very fortunate to be working at Granada University Hospitals back in 2016, when for a number of reasons, we decided to modernize a service provision and to adopt digital pathology for routine clinical use. So as you can see, Granada Hospitals comprises 4 different centers that can be, quite a distance apart, up to 100 kilometers away from the main hub, from the central hospital in the city of Granada itself. The actual service provision is offered to 1 million inhabitants, which translates into approximately 65,000 specimens, histopathology specimens per year. The service provision encompasses 24 pathologists that, as I mentioned earlier, underwent full digital transformation in September 2016. And we definitely adopted for a quick transition from the microscope to full digital transformation, which in fact took us only 4 months. And the experiences of such digital transformation have been collected in this paper that we published some time ago. But essentially, the salient points of our digital transformation experience was that digital pathology essentially associated with an increase of efficiency of about 20% per year. And this was largely due to improved case allocation across the different pathologies of the network, as we saw in the previous slide. In addition to this, we did a survey across the 23 pathologists at Granada Hospitals 2 years after the digital transformation to gauge the level of satisfaction or otherwise with digital pathology. And essentially, the users reflected on an overall quite high level of satisfaction with digital pathology. But we will discuss these points in more detail in one of the next slides. So when it comes to efficiency, in that paper, we describe how pathologists gain approximately 20% on average after the implementation of digital pathology. This was largely due to an increase on the number of histopathology samples, so in other words, an increase in the number of workload, but a decrease in the number of pathologists available to deal with that caseload. Of course, this occurred at the same time with implementation of digital pathology. So it looks like digital pathology certainly helped pathologists become more efficient on the numbers that you can see on the screen right now. The results of the survey that we discussed earlier essentially were that pathologists felt subjectively 20% more efficient. So in other words, they had the impression that they had gained an extra day a week after the digital transformation. But also they felt that the quality of their diagnosis was significantly improved. And this was largely due to the fact that there was a number of digital tools that on an analog workflow are not available. And these digital tools, amongst other things, help pathologists provide better quality and better for their patients. In addition, we see that digital pathology obviously enabled pathologists to report remotely. And this was well before the COVID pandemic hit. So back in the pre-pandemic times, The number of pathologists reporting remotely was 25%, but of course, during COVID times, this percentage increased up to 100%. So the totality of pathologists were able to report remotely and not necessarily turn up for the hospital to do their job. The final question that we asked in this survey is that after having tried digital pathology, would you like to go back to the microscope? And essentially, not a single pathologist wanted to go back to the microscope. So it's not just about efficiency and perceived quality of diagnosis, but also strong preference to remain operating in a digital workflow, and certainly not necessarily to go back to the microscope. So why should pathology be modernized? I mean, what is the rationale why we should bother? Why should we actually invest? Why should we actually take the effort to modernize pathology? Because a number of steps are required to proceed with the modernization of the profession. So why should we take those efforts? Well, the first thing is that it's important to bear in mind that the number of pathologists is decreasing, and it's decreasing worldwide. And certainly in this paper, we can see how the number of pathologists decreases in comparison to what happens to radiologists and anesthesiologists. So pathologists seem to be retiring, but we cannot manage to recruit new trainees into the specialty to maintain the constant number of practicing pathologists. However, the number of cancer specimens seems to be creeping up. And in this part of the graph, we can see represented how those cancer specimens actually keep creeping up year after year after year. So the situation that we discussed earlier on at Granada hospitals, which was essentially less pathologists to do an increasing number of work, is not necessarily unique to our setting, and it's something that also happens in the United States, as we can derive from the conclusions of this paper. Interestingly, also the Royal College of Pathologists of the United Kingdom reached a similar conclusion fairly recently, mentioning that just about 3% of histopathology departments have enough staff to meet clinical needs. So again, this situation whereby cancer is increasingly more common, perhaps because of aging population, perhaps because of better screening programs, etc., etc. This increase in demand is not met by pathologists who can actually deal with these increasing workloads. So this is one of the key reasons why pathology as a discipline needs to be modernized. Also, bear in mind that a lot of what pathologists do involves finding needles in haste, which is time-consuming and is inefficient. And if we focus on the aspect of prostatic core needle biopsy screening and diagnosing, certainly there are a number of inefficiencies there. And these inefficiencies are collected in these papers that we can see in the screen right now. So essentially, there seems to be evidence that pathologists have actually false negative rates in diagnostic biopsy, in diagnosing prostatic biopsies between 1% and 3%. So in other words, unfortunately, pathologists fail to find the proverbial needle in a haystack in about between 1% and 3% of the patients that we see. Obviously, that doesn't sound like much, but when we extrapolate those small percentages to the larger, broader population, obviously the number of individuals affected by these false negatives rates is actually quite significant, especially if we bear in mind that tens of thousands of patients, hundreds of thousands of patients worldwide get prostatic biopsy taken every year around the world. So obviously, small percentages do have quite a significant impact on a population level. And obviously, the challenges are there because, it is sometimes difficult to find, small foci of cancer, especially when the cancer is well differentiated, especially when the cancer is intermingled with benign glands. So that is partly what explains, the false negative rates. But also, another of the challenges in prostatic core needle biopsy diagnosing is that quantifying that tumor and grading that tumor is subjective. So obviously, the Gleason grading, we all know, is subjective. And of course, quantifying the overall tumor burden present on a biopsy specimen also is subjective. So the question is, okay, that is the problem. Can artificial intelligence be part of the solution? And essentially in this paper that we published a couple of years ago, we wanted to experiment with the idea of essentially providing pathologists, the same number of pathologists with the same number of cases, and see what differences were there in their diagnosis when they were assisted with AI compared to when they were not assisted by AI. So essentially, same pathologists reading the same cases, but in two different modalities after a washout period to see how they perform in terms of sensitivity, specificity, but also reading times. And quite interestingly, what we saw is that on average, pathologists, when aided by artificial intelligence, show a 16% improvement in efficiency, in sensitivity, which essentially translated in a 60% reduction in the number of errors. So as we can see in the graph, with the assistance of artificial intelligence, pathologists became more sensitive than without the assistance. But in addition to that, the reading times were significantly shorter when pathologists were aided by AI. So in other words, looks like AI helps pathologists not only be more accurate with their diagnosis, helping pathologists miss less false negatives, but also helping pathologists do a more expedite job and a faster job. So these were the reasons why pathology needs to be modernized. And certainly we believe that artificial intelligence and digital pathology are integral part of the solution. But in my experiences as a digital pathologist and as an early adopter, what is it that pathologists like about digital pathology? One of the first things that pathologists like about digital pathology is how good low power images are on a digital screen compared to the microscope. So if we look at this image on the left, this is normally what we would see when we look through our microscope. And of course, this image was 2.5x magnification, which is probably one of the lowest magnifications possible in routine microscopy. So that is the lowest possible power that you can obtain on a microscope, normally speaking. However, on a digital screen, the lowest possible power is much less than that, because you can easily go up to 0.5x, 0.1x, even, etc., etc., which essentially means that at a glance, you have a very good overview of all the tissue present on that slide. And also that's important from a practical perspective, because that means that your attention gets directed to the areas, to the regions of interest at a single glance, rather than having to be panning and zooming and trying to essentially ensure that you cover all of the tissue present on the slide without leaving behind any missing fragments, which obviously can be worrisome in biopsy specimens that contain multiple fragments. There's always that niggle in the back of your mind as to, am I leaving something back, forgetting to review the fragment that actually contains the bit with dysplasia, etc., etc. So with digital pathology, this is obviously less of a concern because all of the tissue present on the slide is available to you at a glance. Measuring things, obviously, it's something that when you train your residents, your new trainees, and you explain to them that this is essentially how melanoma thickness is established, how distance to margin is established using a ruler placed on the microscope stage. A lot of people who are new to the profession, or that outside of the profession, they get surprised by how pathologists actually, the tools that we use to do this kind of tasks. And the question is, in the 21st century, is it not preferable to have digital tools that help us do a more accurate job, a more precise job? So certainly a more elegant way to tackle tasks that pathologists have to do day in and day out, such as measurements, lesion thickness, overall tumor burden, etc., etc., etc. And of course, that refers to digital pathology without any artificial intelligence assistance, because obviously with artificial intelligence, it's a lot easier. So in a task like this, obviously, screening lymph nodes for breast cancer metastasis, essentially, once you have an artificial intelligence workflow, all you have to do is push a button, and the artificial intelligence will highlight the regions in which it has detected cancer. And of course, it detects cancer, but it's going to show to you, the pathologist, the regions of interest. So you, as a human, have the final word in deciding whether that's indeed cancer or not. And of course, this opens up the discussion as to whether, how far is artificial intelligence going to replace pathologists? In our opinion, that is still decades, if no longer, away from happening. So artificial intelligence is here to help pathologists do a more efficient, more meaningful job with less errors, certainly not to replace pathologists at any point. Another example, like, obviously assessing prostatic core needle biopsies. So obviously in this situation, the challenge is, trying to assess, quantify, and grade the tumor present on that particular specimen. Artificial intelligence is here to help us, and essentially just by click of a button, the artificial intelligence system will give us the overall percentage of invasive carcinoma, the length of that invasive carcinoma, and also will reveal the different patterns, the different Gleason patterns present on that particular slide. All of that to provide an overall Gleason score. So your role as a pathologist here would be obviously to review the output of the AI, to essentially assess what the AI is telling you. And if you agree with that, essentially your job will be to copy and paste these results into your report to validate it and on to the next case. Obviously more efficiently, more elegantly, just using microscope and other tools that perhaps are out of fashion in the 21st century. Another important aspect is that obviously when you're on a digital, on an analog workflow, your pile of cases on any particular day may look something like that. And of course, if you need to find a particular slide, perhaps because a clinician brings you to ask you about a particular slide, your job as a pathologist will be to go through all of that pile of cases until you eventually find the slide and the case that you actually need. So that's on a digital, on an analog workflow. But obviously on a digital workflow, things will be different. Because on a digital workflow, all you have to do is type the patient details here, and the patient will become available to you immediately. Also, the availability of artificial intelligence tools means that you can actually prioritize your cases according to the results of the AI. So perhaps you want to review first the cases in which the AI has detected tumor. So you can actually prioritize those cases, put them on the top of your list. So you can actually start your day by reviewing those cases that perhaps are urgent. You may want to order immunostains and therefore save some time, etc., etc., etc. So certainly a more efficient way to organize your workflow and to organize your day. But the advantages of digital pathology pertain the pathologists, but also the technicians, essentially because in any pathology lab, multiple, tens, hundreds of even thousands of slides get prepared on a single day. And of course, these slides need to be put in order, the cases need to be collated, and the cases need to be distributed. Of course, when you have a full digital pathology workflow, that gets done automatically by the digital pathology system, which means that case assembly and distribution is no longer needed when you have a full digital pathology workflow. It actually gets done by the IT infrastructure and by the digital pathology system. So you won't have to have 3, 4, 5 histotechnologists every day collating the slides, putting them together and distributing the slides across the pathologies. And of course, the histotechnologists could spend their time on more meaningful tasks, like perhaps, molecular workflow, like perhaps grossing, etc., rather than doing these tasks that are perhaps better left to the digital pathology system. What do all the early adopters of digital pathology say about efficiency? So in this paper by Lapon, by a Dutch group, essentially they describe 19 hours per day savings thanks to efficiency gains on a digital workflow. And these 19 hours per day pertain to things like preparing cases for tumor board, not needing to go down to the archive to retrieve slides, not delaying cases because essentially you have a digital workflow and you have a digital archive, which means that previous cases are immediately available to you, etc., etc. So all of these efficiencies put together allow labs to be up to 19 hours per day more efficiently. And that's without including a slight reading time by the pathologist, which is something that this paper tries to address. And this paper essentially reports that pathologists, once they get sufficiently skilled and sufficiently experienced with digital pathology, can be up to 10% shorter in reading times when it comes to the microscope workflow. So it looks like certainly digital pathology on its own, without any artificial intelligence, provides a better tool and provides a better ways of helping pathologists be more efficient in their workflow. So that's essentially what pathologists like about the digital workflow. But there are a number of things that pathologists do not like about the digital workflow. And of course, we have to be balanced and we have to be fair, and we have to address these aspects that are not preferred by the pathologists who work digitally. And one of them is the images at high power. because we talk about the advantages of looking at slides at low power on a digital workflow. Obviously, low power images are better, but the problem that comes at a price, and the price is that at high power, the images do not look as sharp as they would look on the microscope. And for instance, you can have this, take this image of a respiratory epithelium. And certainly this image is taken at 100x, which means that the cilia are obviously perhaps not as sharp as they would be on the microscope. So having said that, I mean, how critical is this? Obviously, I guess, pathologists spend the majority of their time at low power, which means that, perhaps all things considered, having a better low power image is preferred to having a high power image. So on the whole, looks like the compromise is about right. What about other cases, like perhaps gastric biopsies? Again, finding very small things is somewhat trickier in the digital workflow. The reason being that scanners scan slides up to 40x in the current FDA approved scanners. So that means essentially that anything greater in power than 40x has to be digitally enhanced, which means that the pixels have to be somewhat recreated by the system, which involves obviously some degree of blurriness. So obviously we're looking for very small things like Helicobacter in gastric biopsies. I mean, you can still see them there, but perhaps the image is not as sharp as it would be on the microscope. So it does require a certain amount of getting used to things to be able to detect these very small things like bacteria, differentiate mitosis from apoptotic bodies, etc., etc. But on the whole, as I mentioned earlier, generally speaking, digital pathologists feel better off with a better low power image at the price of somewhat not sharper high power images. So on the whole, the compromise seems to be worthwhile. Other things that pathologists do not like is that obviously you have to adjust to a digital pathology workflow. And some users may not find that transition necessarily very easy. So these users, these pathologists, obviously need to be addressed on an individual basis to assess what the problem is and see what solution can be given there. Perhaps they need more coaching, perhaps they need more training, perhaps they need some adjustments to the workflow to ensure that the transition from the microscope to a full digital workflow is successful. But the point of the matter is that, of course, there will be detractors to the digital transformation process. And the advice here would be to obviously to coach and to look at individual needs to ensure that these users can successfully transition from the microscope to digital pathology. Okay, so those are the things that pathologists find challenging when transitioning to a full digital workflow. The question is, assuming that that's what we decided that we want to do, and we want to certainly embark in modernizing the profession, adopting digital pathology and AI, how do we get started? Where do we begin? And essentially, the starting point is optimizing the workflow, optimizing the way that slides are prepared for reasons that I will explain later. But essentially, this becomes the foundation of everything else. So slides need to be prepared in a somewhat different way as how they're prepared in a microscope-based workflow. The next step would be LIS and tracking software integration, because essentially this IT infrastructure becomes the foundation upon which digital pathology is built for reasons that we will explain later. But it's very important to realize that without addressing some changes in the way that slides get prepared, without addressing some changes in the workflow optimization, and without addressing LIS software integration, we cannot progress to the next stage, which is digital pathology. And of course, without digital pathology, we cannot progress to the next stage, which is the implementation of artificial intelligence in routine clinical practice. So it has to be a phased approach towards modernizing pathology, starting with the way slides get prepared, then addressing integration with the IT infrastructure pertaining especially the LIS. Once we have that in place, we can certainly consider digital pathology for routine diagnosis. And at that point, we can certainly then consider the use of artificial intelligence to help pathologists do a better job, like we discussed earlier. So how do slides need to be prepared differently? The barcodes on the slides are essential in a digital pathology workflow, essentially because the barcodes contain the information necessary to assign the whole slide image obtained by the digital pathology scanner to the right case and to the right pathologist. So this happens thanks to the information contained in the workflow in each slide. Obviously, if the barcodes happen to be faulty, happen to be of not optimal quality, the scanner will have challenges identifying the barcodes on the particular slide, and therefore that may create a malfunction. And the digital image cannot be assigned to the right pathologist and to the right case if the barcodes are not of the optimal quality. So obviously addressing how the barcodes are printed is important in a full digital pathology workflow. Another aspect is that obviously artifacts like bubbles, like pen markings, etc., can trip a digital pathology scanner. So it's very important that these artifacts get controlled and get adjusted for to ensure that the scanner can obtain a faithful digital replica of that slide. So that digital image can be meaningful to pathologists for them to render an appropriate diagnosis. Another crucial aspect is that slides need to be properly dry and need to be of good enough quality to be put into the scanner. Obviously, if the slides have mounting media oozing on the sides, that means that if we put that slide into the scanner, the optical elements of the scanner will hit that glue and will spread and smear the glue all over the preparation with a subsequent lens contamination and the subsequent scanner malfunction. So obviously, this needs to be addressed, and we need to ensure that the slides that we put into the digital pathology scanner are properly nice and dry so they can go into the scanner without creating any malfunction in the scanning system. So let's look at the importance of the LIS in the entire digital pathology workflow. So we talk about how slides need to be prepared differently. Now let's talk about the importance of the LIS integration in the digital pathology environment. Remember, the heart of digital pathology is to obtain a digital replica of the whole slide, of the conventional glass slide that we call the whole slide image. And in order to achieve that, we have to have a barcoded glass slide, as we mentioned earlier. So the job of the scanner is to obtain a digital replica of that glass slide. That digital replica of the glass slide is then portrayed in a viewer. So the viewer essentially replaces the microscope and shows the digital image acquired by the digital pathology scanner. However, the job of a viewer is not to organize the workflow, because the job of the viewer is essentially to show the digital image as a replacement for the microscope. However, the job of organizing the workflow pertains to the LIS. And the reason for that is that the LIS contains all of the information regarding patient, regarding history number, regarding the number of blocks that case has in particular, regarding any outstanding that are still pending in the workflow, etc. So therefore, the LIS-centric approach is what facilitates the transition from the analog world to full digital pathology. And it's essentially this interchange of information between the digital pathology system and the LIS system what permits pathologists to replace the microscopes and to go for a full digital workflow. Okay, so let's look at possible challenges, and more importantly, what solutions and how to tackle these challenges. So we mentioned that slides need to be properly clean, dry, and ready to be put in the scanner. We also mentioned the importance of the QR code and the barcoding to ensure that the digital pathology system can actually read them. So the question is the quality of our QR codes sufficiently good? Perhaps there is no way to know beforehand without doing a trial, and essentially to see how many errors do we get in relation of these barcodes. Obviously, errors are inevitable, but the question is that these errors need to be at a low rate. Perhaps if we get errors in the 1 in 1,000 sort of rate, then perhaps that means that the quality of our QR codes is sufficiently good and we don't need to introduce any modifications. But certainly, if our error rate is greater than that, we certainly need to consider replacing QR code printers and perhaps consider using etching printers that actually produce better quality QR codes that are more resistant to artifacts. Another important aspect to bear in mind is that film cover slipper is definitely preferred on a digital workflow. Essentially, the reason for that is that the slides provided by film cover slipper are normally dry in a matter of seconds, clean and rid of any residue that may interfere with the scanning system. So for that reason, film cover slipping is definitely preferred. Another crucial aspect is the batch versus continuous workflow. So essentially, imagine that we have a digital pathology scanner waiting for the slides to become available to start digitizing them. With a batch approach, essentially we have a large amount of slides that arrive all at once at the digital pathology scanner. So the scanner essentially sits unused for long periods, waiting for that avalanche of glass slides to become available. And this is, the way that the majority of pathology labs operate today. Problem there is that the digital pathology scanner can only read one slide at a time. So today, the digital pathology scanners only have one optical mechanism to be able to read a single slide at a time. Therefore, a bottleneck is created at the scanning process, which means that you have to either buy more scanners or consider changing your workflow in a different way. The alternative would be to adopt an approach, but a continuous workflow approach, whereby small batches of glass slides are generated continuously throughout the day. And this way, we ensure that the scanner is actually in use pretty much around the clock. So therefore, the scanners always will create a bottleneck. The problem is, how do we minimize this bottleneck? And again, there's perhaps two ways of doing it. Obviously, one way would be to obtain more scanners, at significant cost, or the alternative would be to consider adopting a continuous workflow approach whereby smaller batches become available throughout the day, so the scanner can be continuously scanning. And of course, here having a continuous workflow and having a continuous workflow tissue processor becomes incredibly important to maximize and to possibilitate this continuous workflow approach. Another question would be LIS integration, because the question sometimes, okay, should we opt for an LIS-centric versus an image-centric workflow? And in my opinion, the LIS-centric approach is preferred. The reason for that is that in pathology, cases are very redundant. So the pathologist takes a look at the preliminary H&E, and fairly often immunostains are required, which means that the case should change status, which means that the case is not ready for review if there are immunostains pending. So for that reason, the case status of the cases of the slides that pathologists see every day need to change according to the readiness of the case. So if a case is not ready because there are immunostains pending, that case should move to a different folder where it's out of the way of the pathologist. So the pathologist doesn't get confused reviewing cases that are not yet ready for review, because essentially there are techniques pending. So to avoid this kind of confusion, an LIS-centric approach is essential. But not only this, there also has to be a significant amount of integration and interoperability between the LIS and the digital pathology platform to ensure that the right case goes to the right folder according to the level of readiness. Okay, so we talk about digital pathology workflow. Now let's talk about how AI can be deployed in routine practice. So the essence of computational pathology, the essence of applying artificial intelligence in routine practice, means essentially that the pixels obtained by the digital pathology scanner are made available to the artificial intelligence system, so the artificial intelligence system can provide an output on that digital image. So that's essentially the core, the root of artificial intelligence in pathology practice. One of the main problems that can arise in this concept is essentially making these pixels available to the AI computers, so the AI can actually produce that output. And this can happen when the image, the pixel exporting is restricted in some way. So in other words, we cannot export the pixels obtained by the digital pathology scanner and make them available to the AI system, so the AI system can actually operate with those pixels and provide a meaningful output. That is the first difficulty, the first challenge that we have to address. So obviously, in an ideal world, we would like to have unrestricted image exporting in order to make available these pixels to the AI system so it can actually do its job. The second challenge is, okay, we talk about having an AI system that reads these pixels, but this AI system can be deployed perhaps, in an on-premises server. And that in itself also brings about a series of challenges, because obviously having a server, a computer on premises has a series of limitations. First of all, is that obviously it is expensive, because essentially you're buying a computer that you're deploying on premises, on your own premises in the lab, so the pixels can be read by the AI system hosted, stored in this on-premises server. The problem with that is that anyone who has bought any computers knows that the computer will be obsolete in a matter of years. So that is one of the challenges as well. So the system that you deliver on premises will be expensive, will be limited, and obviously will be a number of maintenance that will be required to maintaining it operative. So those are the limitations of on-premises serving. The alternative would be to have a cloud approach, whereby this computer is essentially hosted in the cloud, which means that this is a more inexpensive approach to the problem, because essentially you're not buying a computer, you're basically hiring computing facilities in the cloud. The cloud, by definition, is unlimited and is no maintenance is required, because that is the problem of the clouds, to maintain and to update the cloud servers as required. So two different approaches to deploying AI in routine practice: on-premises servers versus cloud servers. Let's also discuss what the computational pathologist workflow would look like. So let's imagine two different pathologists. So pathologist A on the top essentially has a general digital pathology viewer that he uses for his general cases. He also has an algorithm that he uses for prostatic biopsies. So essentially, this pathologist would have to log in and out of one platform onto the other to review prostatic core needle biopsies, say, for instance. But also, this pathologist has a third artificial intelligence provider for melanoma, say, for instance. So in this hypothetical pathologist workflow, the pathologist will have to be logging in and out of different platforms to review different case types. Obviously, it's perhaps not the most efficient way to tackle things, because any efficiency gains will be eroded by having to log in and out of different platforms, depending on the use case. The alternative would be what we have with pathologist B at the bottom, where essentially she has a common platform for all uses and cases. So she can actually sign out her general pathology cases. She also has AI integrated into that platform for, say, prostatic core needle biopsy reviewings. And she also has perhaps a third-party algorithm for melanoma reporting. So the need to be logging in and out of different platforms is obviated when a common platform is used for all cases and all needs. So to start wrapping up my session, as a model of summary, let's just mention that pathology as a discipline is under strain for the reasons that we have discussed. So the number of cancer cases is because aging populations, because better screening programs, etc., etc. Whereas at the same time, the number of pathologists available to cope with this increase in caseload is diminishing. We also have discussed how pathologists are limited by the current technology. I mean, using the microscope, using rulers to measure tumor thickness, etc., was okay in the 19th century, was okay in part of the 20th century. It's definitely not okay in the 21st century, because essentially there are better tools available at the moment that permits pathologists to do a more efficient, safer job. Not to mention, of course, the importance of AI in the pathology workflow. We've also seen how digital pathology and AI are showing evidence of benefit. Benefit in terms of better efficiency, of better user satisfaction, and more importantly, better diagnosis for their patients in terms of accuracy and in terms of improved overall patient safety. We discuss, how to approach the digital transformation of pathology and the implementation of artificial intelligence. And we've mentioned how it's important to start with optimizing the workflow, to then move on to the LIS integration to enable the deployment of artificial intelligence and digital pathology in common routine practice. So with that, I would like to thank you for your attention today. And I would like to leave you with this quote that I'm sure many of you would have read, but essentially mentions that a mystic prevention prevails among clinicians who believe that the pathologist, given only one piece of a patient tissue, has all the ingredients necessary to produce a statement of absolute truth. More dangerous to mankind is a pathologist with the same concept. So certainly, providing statements of absolute truth can be dangerous for pathologists. So with that, I would like to thank you for your attention today, and would like to open up the floor for questions. Thank you very much.